Okay, so this lecture's on language, following the principles of neuroscience curriculum. And this is the syllabus that I'm have been referring to. And so objectives for the lecture today, understand the difference between language and speech, know the basic neuroanatomy of language production and comprehension, and recognize the presentations of different types of aphasias, and relate these presentations to the sites of underlying lesions. So language versus speech. Language refers to a structured system of communication, which includes speech, writing, sign language. And when we talk about language from a neurological perspective, that's encompassing the processes by which thoughts are translated into an ordered pattern of motor output to produce speech, for example, or gesture or written language. And then at the sensory pole, language processes decode symbols or sequences of sounds into meaningful representations. When we talk about speech, that's a narrower term, which refers just to the motor production of verbal language. And so understanding the difference here is important in understanding the difference between dysphasias, which refers to disorders of language, and dysarthrias, which refers to disorders of speech. Specifically the motor output of speech. And just to note that aphasias, the word aphasia is kind of used interchangeably with dysphasia. Aphasia technically means total loss of language, and dysphasia technically means partial loss of language. But the syllabus uses aphasia, and it's kind of used interchangeably clinically. And so I thought we should just start by touching on the importance of language. It would be quite a nice way to open an essay on this topic. So language obviously forms a core aspect of social behaviour, allowing us to express ourselves. Loss or impairment of language can have a devastating impact on patient quality of life. It can be incredibly frustrating for patients, and also very isolating. So language rehabilitation or tools to aid alternative means of communication are really important in improving the quality of lives of patients facing language impairment. And so pictured here is a patient with motor neuron disease, which commonly leads to progressive loss of language. And he's using a blink-controlled speech generating device to enable communication. And so just touching on some causes of disordered speech and language, the four main types of dysphasia, which we'll be covering in today's lecture, are expressive, receptive, conductive, and global, with different patterns of presentation caused by brain lesions of various locations. For example, in stroke, neurodegenerative disease, brain tumors, head trauma, or epilepsy. And then dysarthrias, so disorders of speech, can also be caused by brain lesions or nerve or muscle disease anywhere along the pathway from the motor cortex to the bulbar muscles involved in speech production. So there are a number of overlapping causes of dysarthrias and dysphasias, but I've tried to highlight the difference between dysarthrias concerning the kind of motor production of sound making versus expressive dysphasias, which is more to do with the ability to form coherent language rather than the physical production of speech. And then I just wanted to highlight a couple of other causes of communication disorders, including hearing or visual impairment, neurodevelopmental or learning disabilities. But that's not really the focus of today's lecture. We'll just mainly be focusing on the language side of things. So there are 6 components of language that we think about for testing in neurological exams. And these are comprehension, repetition, naming, fluency, reading and writing. And kind of testing these 6 components can offer insight into the site and cause of the language disorder. So going into some anatomy basics then, for localizing site of lesions. So I think there are 3 main structures to know really well for the purposes of undergrad and clinical exams, and these are Broca's area, important in language production, Wernicke's area, important in language comprehension, and the arcuate fasciculus, which connects the two and is thought of as particularly important in repetition and reading. And so where are these structures? Well, language is a lateralized function, so meaning that one hemisphere plays a dominant role. And in most people, it's a left-sided function. However, there is an increased incidence of atypical right hemispheric language dominance in left-handed people, who form about 10% of the population. So language centers are left-sided in 99% of right-handed people compared to about 70% in left-handers. Okay, so looking at the anatomy in a bit more detail then. So Broca's area, thought of as important in speech production, is found in the left inferior frontal gyrus, Brodmann areas 44 and 45. It's supplied by the superior branch of the middle cerebral artery, and is a center for motor programming of speech, articulation, movements, with connectivity to the motor cortex. Broca's area was discovered by French physician Paul Broca in the 1860s, and his famous patient Tan was central to this discovery. So Tan acquired his nickname because following brain damage by an epileptic fit, his speech was limited to the single syllable Tan. Understanding of language remained intact, and he had normal intellect and could communicate all of his needs by way of gestures. And after he died, Broca carried out an autopsy and localized greatest damage to the left inferior frontal gyrus, concluding that this region formed the seat of articulate language. And this was actually the first widely publicized evidence of localization of cerebral function. So a very significant discovery in neuroscience. And then Wernicke's area is shifted a bit more posteriorly in the superior temporal gyrus. And this was discovered by German physician Karl Wernicke, who was heavily inspired by Broca's work. It's supplied by the inferior branch of the middle cerebral artery and is thought of as a center for language comprehension, both written and spoken, and receives inputs from the primary visual cortex and the primary auditory cortex. So Wernicke described this distinct sensory aphasia characterized by normal fluency, but disordered speech and loss of understanding of speech. And he identified lesions of the left temporal lobe, so corresponding to Wernicke's area, as responsible for these isolated sensory deficits. So just a side-by-side comparison of the 2 types of aphasia. So just to highlight that patient Tan suffered a very kind of severe form of motor aphasia where his speech was limited to just one syllable. But patients can display kind of highly variable motor language deficits depending on the extent of their lesions. So kind of key characteristic features of Broca's aphasia would be halting and effortful, agrammatic speech, but normal comprehension, missing out words and difficulty forming full sentences, and reduced kind of spontaneous speech output. And patients tend to be aware of their errors and correct themselves and get quite frustrated by their difficulties. Whereas in Wernicke's aphasia, or receptive or sensory aphasia, speech is fluent and flowing, but kind of lacks meaning. It's sometimes described as word salad, kind of made up new words can be used alongside real words, and patients tend to lack awareness of their language deficits, and they don't self-correct, and obviously impaired comprehension as well. And I just thought a handy way to try and remember the difference would be Broca's aphasia is characterized by this broken, halting, effortful speech, and Wernicke's by this sort of word salad type speech. Okay, so on to the third key component, the arcuate fasciculus. So this is a white matter bundle which provides reciprocal connectivity between Wernicke's area and Broca's area, and is important in allowing us to respond or repeat language through temporal control, so control from Wernicke's area over Broca's area. So it's particularly important when language reception feeds directly into production. So for example, if you were repeating something or reading out loud. And that's illustrated on this slide. So for example, if you were listening to a word, you have primary auditory cortex inputs to Wernicke's area, connected to Broca's via the arcuate fasciculus, and feeding kind of motor instructions to motor cortex. Sorry. And then if you were reading aloud, you've got primary visual inputs into Wernicke's area from the occipital cortex. And Wernicke went on to describe a third type of aphasia known as conduction aphasia. And in these patients, they have relatively intact verbal fluency and comprehension, but display severely impaired repetition and also impaired reading aloud. And he theorized that these symptoms were the result of damage to the arcuate fasciculus connecting intact Broca's and Wernicke's areas, resulting in loss of temporal control over Broca's area speech output. And this was later supported by post-mortem studies. So Wernicke's three-component model of Broca's area, Wernicke's area, and the interconnecting arcuate fasciculus was later expanded by Lichtheim to incorporate this theoretical concept center. So it became clear that the three-component model couldn't account for all aphasia presentations, and there were these two other types of aphasia, transcortical sensory and transcortical motor, which could be accounted for by this expanded model. So transcortical sensory aphasias were characterized by impaired understanding of heard repeatable words, and transcortical motor by impaired verbalization of thought. So this sort of vague notion of this concept center, which wasn't actually anatomically localized, but was sort of purely theoretical at the time, accommodated for the fact that there are several aspects of normal language function in which external sensory inputs, so for example, hearing or reading a word, do not directly feed into language output. So for example, if you were just monologuing based on internal thought. So how does this all compare to the modern day perspective of language function? Well, our understanding of language has gradually been replaced by a much more complicated picture with the development of non-invasive functional brain imaging. So it's now appreciated that Broca's aphasia does not necessarily imply an isolated injury to Broca's area. And in fact, isolated damage to Broca's area is now appreciated to produce a mutism, which gradually recovers, usually completely resolves over time. And reinspection of patient Tan's preserved brain demonstrated that the lesion actually extended significantly beyond Broca's area. It's been found that comprehension is even more widely distributed across the brain, and language function is now attributed to extensive temporoparietal frontal cortical networks in both hemispheres. And this atlas was formed based on functional MRI data from over 800 individuals by overlaying the individual activation maps during reading aloud. So fMRI is measuring small changes in blood flow with brain activity. And so this just highlights the extensive bihemispheric activation involved in this language function. So this slide is just to summarize the key features of the main types of dysphasia, which you need to know for your reference. And then just some MCQs. So an easy one to start with. So if you just try and think about what your answers would be, and I'll show them in a few seconds. So you can identify an area important in the comprehension of spoken and written language, and an area historically recognized as the seat of articulate language, and the white matter tract connecting Broca's and Wernicke's. And then if you can try and describe the anatomical location of G and D, so in relation to sulci and gyri. Okay, so I'll flip over the slide now. Okay, so comprehension, this is Wernicke's area, Broca's area, and the arcuate fasciculus connecting the two. And G, Broca's area is in the left inferior frontal gyrus. So, and D is in the left superior temporal gyrus. And then some more. So a stroke affecting which arterial territory is most likely to result in a receptive or Wernicke's aphasia? And then a lesion of which of the following structures would present with intact language comprehension but impaired verbal repetition despite fluent spontaneous speech? Okay. And then just got a slide to demonstrate the arterial supply because I didn't actually put a picture in. So you can see this is the superior division of the middle cerebral artery supplying Broca's area, and this is the inferior division supplying Wernicke's area. And then finally there's a table which you can either quickly draw or try and mentally fill out for the key features for the main aphasias. Okay, and these are the answers. So Broca's, also known as motor aphasia, comprehension is preserved and they tend to be aware of their deficits, but the key feature is loss of fluent speech output, whereas Wernicke's is kind of the opposite. Comprehension is lost and they are unaware of the deficit, but speech is fluent and flowing, even though kind of doesn't make sense and it lacks content. And then with a conduction aphasia due to lesion of the arcuate fasciculus, comprehension is intact and they're aware of the deficit, and speech can be fluent when it's spontaneous, but it's characterized by these deficits of repetition and reading due to the loss of connectivity between Wernicke's and Broca's. So that's all I have. I don't know if anybody has any questions. It's pretty brief, it's quite a short section of the syllabus. But thank you all for listening, and I'd really appreciate it if you could fill in the feedback form. I'll just leave this slide up for a second.